So good afternoon and welcome to this TBS webinar. I am Antoine Nico from Medimaps, and today's presentation will be on the trabecular bone score, which is delivered by the TBS Osteo software working on the DEXA machine. For this presentation, and I'm very pleased and honored to introduce you to Dr. De Villiers. Dr. De Villiers is gynecologist and obstetrician in Tygerberg, Cape Town, specialist in infertility, post-menopausal medicine, osteoporosis, reproductive endocrinology. He is also member and current president of the National Osteoporosis Foundation of South Africa. And also very pleased to introduce you to Dr. Lipschitz, who is a specialist physician and subspecialist geriatrician in Rosebank, Gynaecologist. His special interest includes assessment and management of osteoporosis and metabolic bone disease, and the assessment and management of memory disorders. Dr. Lipschitz is also member and current vice chairman of the NOFSA organization. Today's topic will be an introduction, will be performed by Dr. De Villiers, and we'll also have the chance to have the experience shared by the case studies of Dr. Lipschitz. At the end of the session, please write all your questions on the Q&A that you have access to from the Zoom platform. And at the end of the session, we will be able to share this question that you may have to our two speakers. So thank you. Please, Dr. De Villiers, you may start now, and thank you for sharing.
Okay. I'm just kidding. Thank you very much, Antoine. I'm just going to put this on the slideshow. Can you see my slides? Hello?
Yes, we do, Doctor.
You do. Okay. Good evening, and thank you for joining us. We're talking today on the trabecular bone score, which we'll call the TBS, to explain to you exactly what it is, how you can use it, and then Stan will, after me, go into some practical cases. Now, we always just have to set the scene in terms of osteoporosis. So you all know that osteoporosis is a very prevalent disease, and that it affects about 1 out of 3 women and 1 out of 5 men. The point why I'm alluding to this is that we do have medication available to lessen the impact of fractures. And if we have better tools to predict the patients who are at risk of fracture, we obviously can not only save a lot of fractures, but as you can see here, we can also save a lot of money for the healthcare system. So you all know that osteoporosis is a silent systemic skeletal disease, and it has 2 characteristics. The one is low bone mineral density, which you can see on the right-hand side here. And this is mostly captured by the conventional DEXA or dual X-ray absorptiometry that we do. But there's also a second component, and that is the microarchitecture of bone. When we talk about TBS, we talk about the spine, and vertebral bone microarchitecture is what we call a trabecular structure, which you can clearly see here. So although bone mineral measurement with DEXA is the gold standard for osteoporosis, we all also know that the majority of fractures will actually occur not in the osteoporotic range with a T-score of -2.5, but in the so-called osteopenic zone of lesser than -1 and between -1 and -2.5. Now, to just put this in perspective, the risk of a fracture raises as you get older, and that is the blue line, but the total amount of fractures is actually not that much because there are not that many elderly people compared to people at the age in the osteopenic zone. So your risk is higher as you get older, but the majority of fractures actually will still occur in the osteopenic zone. So how can we improve our predictability of fractures? By using both the bone mineral density as well as the trabecular structure. So what is TBS, the trabecular bone score? This is a system that's driven by software that is added to a normal DEXA machine. And there are quite a few of us in South Africa that already have this option added to our machines. So the TBS will independently report on the parameters correlating to the trabecular bone structure, but it's never meant to be used on its own, and it's to be used in addition to the information that we get from the DEXA. So it is an imaging software that is a complement to DEXA, where the TBS score is an index mostly related to bone architecture and an independent parameter for fracture risk prediction. Now, I'm not going to try to explain to you the physics of how this software works, but what you can think about, and that's how I got my head around this, is thinking about evaluating the health of a forest by using satellite technology. So you can do it by taking a photograph of the forest and then counting the number of trees on the satellite image, and then the bone mineral density correlates to counting the trees, which would be the sum of the trees divided by the surface of the forest. But obviously it's very difficult counting the trees there. So there's an alternate way which you can use, and that is by looking at the size of the clearings that we have in between and the specific structure of the clearings in between trees. So not counting the trees, but looking at the areas that are not covered by trees. And this is what TBS does. So the exact physics about how that's done is the sum of the square differences between clearings. So don't worry too much about that, because the software will determine that, and that correlates very well with a fracture risk prediction independent of DEXA. So just on this slide to show you that at the top here, we have the first bone mineral density reading. I'm not giving the reading, I'm just saying that this reading and this reading is exactly the same. But the same reading can be associated with either a well-structured trabecular bone, and the TBS will interpret it like this, or you can have a lower bone mineral density, which would look like this to the TBS software. And then the TBS software will work out a score. Now, this is not a score expressed in any units. This is a particular TBS unit, but we're going to put that in perspective to the bone mineral density by looking at the next picture. So this comes from my unit at Panorama. And in this particular case, the TBS between L1 to L4 gave a value of 1.186. Now, unfortunately, the software relates that to a T-score. So that is, again, the score related to the TBS expected for a young adult woman. It's then expressed to you in the same way as we do the DEXA. So in this particular case here, the TBS score actually falls into the osteoporotic range, which is the red range. Now, just seen on its own like this doesn't clinically mean anything to you. So you have to look at the next graph that it gives us. And here we have the L1, L2, L3, and L4, and it will give us the reading on the TBS and the reading on bone mineral density. And then you can go to the value that is valid for the DEXA, and in this case it is L1 to L4. And we see that the L1 to L4 for TBS was low at a -2.9, where it was fairly normal in terms of bone mineral density. So that relates to the second example that we saw on the previous slide. So here you can, so mostly in clinical cases, you will get that there will be a fairly good correlation between the TBS T-score and the bone mineral density T-score, but there are the exceptions, and we'll get back to that now. So once you have actually done this, in order to make a fracture risk assessment, you need to use the FRAX model. Now, most of you are well aware of the FRAX model, and the FRAX model gives us a 10-year prediction of either any major osteoporotic fracture or for hip fracture. I'm going to show you on the next slide, a slide which I'm not actually allowed to show you, but it doesn't give away any of the secrets. But this is a South African model of FRAX, which is at the moment in the testing phase, and for which we thank Professor Bilkis Kassem and the team from KwaZulu-Natal who did all the hard work. So what we do with this model, which will be specific to the South African population, is that you add in the risk factors here, and it will then give you a risk prediction for the next 10 years of a major osteoporotic fracture, which in this case was 1.6, or for hip fracture of 0.1, which is very low. The beauty of using the two systems together is that, if you remember in the beginning, I said that the TBS score only reflects the spine, the trabecular structure of the spine. Now, if you have a look at the FRAX again only uses the bone mineral density of the femur neck. And that's been one of the big criticisms of the FRAX system, that it doesn't take into account the spine. So when you then combine TBS, and this is the adjustment that you can make here that is built into the software, you can combine the two, and that will then give you a much better FRAX prediction. So this was, in this particular case, the FRAX adjusted for TBS, and that changed the major osteoporotic rate slightly to 2.5, which is slightly less, and the hip fracture to 0.2, which is slightly more than it was without the TBS. So this is then the way to use this, that you use it in addition to DEXA, but that you also try then to combine the TBS with the FRAX, which is based on the neck of the spine. So if you do that and you use both the TBS and the DEXA, you will find that the total number of major osteoporotic fractures or risks will increase from 54% to 70%. So the TBS, in addition, will reclassify 30% of osteopenic patients to be at high risk of fractures. So what this clinically means, if you combine the two, you will probably treat 30% more of patients. So there are certain conditions for the use of the TBS. As I've said, only lumbar spine scans can be used. Only adults or persons older than 20 years, and not many of you will have the indication to do a younger than a 20-year-old. And then the patient has to fall within the BMI range of 15 to 37. So it is not a separate examination that's done. This is a software that is applied to the normal DEXA scan, and the acquisition of the scan is exactly the same as before, and it doesn't really add any time to the radiographist that will be doing the test. So there are three main groups that can be of clinical benefit. So most of you will probably use it in primary osteoporosis or post-menopausal osteoporosis, where TBS is an independent predictor of fracture risk complementary to BMD, or in secondary osteoporosis, TBS may have a higher correlation to fracture than just using DEXA. So we are looking here at osteoporosis secondary to corticoid usage, rheumatoid arthritis, type 2 diabetes, hypothyroid, parathyroidism, breast cancer, and it is strongly recommended to use the combination under these cases. And then it can also be used, and Stan will show some examples for follow-up monitoring of therapy. So just to sum up then, our key value-added benefits of trabecular bone score is in osteopenic patients, where the combination will result in 30% of patients being changed from osteopenic into either normal or to osteoporotic. And certainly in patients whose FRAX threshold is close to the intervention threshold, where you're just not sure whether you're going to be treating or not, it will certainly help there. And then, as we said, the patients with secondary osteoporosis, but also in the elderly patient with osteoporosis of the spine, where often the DEXA value will just be incredibly high, but it's because of sclerotic changes, and the TBS score will be of a great help in those cases. Thank you very much that I could give this introduction, and I'm now glad to hand over to Dr. Stan Lipschitz for the case presentations.
Can you hear me?
I can hear you.
Okay, I'll just share my screen. Evening, everybody. I'm going to follow Toby's talk with a few case studies from my own series. Just to introduce the topic, Toby's already outlined for you that what we attempt to do in osteoporosis is to predict the risk of fracture. And the risk of fracture is based on several factors, including low bone mass or osteoporosis, as we generally define it. It's also related to poor bone quality, which up to now we've had very little ability to measure in practice. And then obviously falls-related risk factors are also important in fracture risk assessment. So the TBS really defines the bone quality as best we can at present. These are recent guidelines. There's several recent guidelines, unfortunately not our own, that have been published. But the important thing with all the guidelines is the determination of fracture risk and the division of patients into those at very high risk of fracture, those at high risk of fracture, and those at low risk of fracture. And you can see in all three, the FRAX probability is defined at a specific criteria. For major fracture, more than 30%, and for hip fracture, more than 5% for severe fracture, for very high fracture risk, and then greater than 20% and 3% for high-risk patients. So the role of TBS would be to move patients in between these risk categories in order to define how we treat them. This is from a recent publication from the American Association of Clinical Endocrinology, and just defining their points on TBS. So as Toby said, it does predict fracture risk independent of BMD and enhances fracture risk capability. It appears that TBS is more important in younger women, although nobody knows really why. And then it's important in certain secondary conditions such as type 2 diabetes and primary hyperparathyroidism, just confirming what Toby said earlier in this guideline. We haven't yet added it to our South African guidelines, but I presume we will when we update them. So the first patient is a Miss JM. She's 73 years of age. She had primary hyperparathyroidism in 2008, and she also had a hip fracture. She was treated with Livifem hormone therapy for about 6 years, from 2005 to 2011. And then she was treated with strontium ranelate for about 7 years. And after 2018, she was treated with vitamin D only. This is her bone density scan. This is her lumbar spine reading. You can, if you just look at the lumbar spine, you can see it's spuriously elevated because of arthritic change. If you look at the bottom there where I'm pointing, her bone density while she was on the strontium ranelate increased by 17.2%. Now, at least some of that is spurious, relating to the osteoarthritic change. And then in the following year, when she was not on treatment, there's a 1% decline in bone density. This is her left femur. Her T-score at femur neck is minus 2.2 standard deviations, minus 1.8 standard deviations. So based on DEXA criteria, she's not defined as osteoporosis. For those of you who understand other clinical risk factors, you already know that based on her maternal history of fracture and her age, she almost certainly does have osteoporosis. Again, you can see the 9.7% cumulative increase in bone density while on the strontium ranelate, and a following 3.2% decline in bone density while on no treatment. And you see similar readings at the other hip, where there's been a 4.3% decline in bone density. So this is her trabecular bone score. Toby showed you the readings earlier, and you can see her trabecular bone score is 1.131. Any reading below 1.3 is of concern. And you can see she fits into the red or high risk category on this. And then on the comparative readings, you can clearly see the significant decline in the last year of the TBS. So if you look here, this is the TBS year by year. You can see there was a 9% increase in bone density initially, and then this precipitous decline in bone density by 14.5% over the last year. As Toby said, you can add this to FRAX. So this is her FRAX. Unfortunately, I don't have the South African database, so I'm using the UK database. You can see put in her details together with the parental hip fracture. And based on a T-score at the femur neck of minus 2.2 standard deviations, her 10-year probability of a major fracture is 22%, and a hip fracture 11%. If one adjusts that with TBS, the risk increases slightly, so it will not really influence your treatment, but the risk increases to 24% for major fracture and 12% for hip fracture. Now, if you take those risks and you then apply them to the algorithm for treatment, she falls into the very high risk profile for fracture. So remember, based on her T-score, which was minus 2.2, if you standard deviations, if you looked only at that, you probably wouldn't treat her. In this instance, she's at very high risk, and you would in fact consider anabolic therapy or more aggressive treatment and longer treatment in this patient. The second patient is, she's a 52-year-old female. In 1994, when she was a young lady, she dived into a pool and she suffered vertebral fractures. And at that stage, she did have a DEXA scan, and the Z score was minus 1.6 standard deviation. So these were high trauma fractures. She was then seen by me in 2019, aged 51 years. Her T-scores were minus 1.9 standard deviations at lumbar spine, minus 1.2 standard deviations at femur neck. And there was then a possibility of primary hyperparathyroidism based on a marginally elevated serum ionized calcium. The upper limit of normal is 1.3, and a marginally elevated parathyroid hormone level. Upper limit of normal is 72 picograms per ml. Also, her 24-hour urine calcium level on no calcium supplement is right at the upper limit of normal at 6.69 millimoles per 24 hours. At that stage, I didn't feel she satisfied criteria for further investigation and certainly not for parathyroidectomy, so I treated her conservatively. She was seen a year later. She still has no symptoms of menopause. Her parathyroid hormone level is slightly higher. Her calcium level and her 24-hour urine calcium levels are slightly lower. This is her bone density. You can see at lumbar spine, we use T-scores because she's now over age 50. So her T-score is minus 2.5 standard deviations. And you can see between 2019 and 2020, there's an 8.1% decline in bone density. This is the left femur. If you look at the graph here, you can clearly see the significant decline in bone density over the past year. T-score at femur neck minus 1.5 standard deviation, but a decrease in bone density by 4.6% over the past 12 months. Similarly, a decrease by 5.4% at the right femur total. Now, if one's considering primary hyperparathyroidism, we like to look at the bone density at 1/3 radius, which is the site usually most affected. And you can see her T-score in 1/3 radius is only minus 0.6 standard deviation. So that's not supporting the diagnosis of primary hyperparathyroidism. This is quite revealing because you wouldn't expect a 51-year-old woman to have a trabecular bone score at these levels. You can see it's 1.169, which is very low. So it's lower than the bone density. And once again, you can see this precipitous decline in trabecular bone score by 13.6% over the last year. So the clinical dilemma in this case, and I still haven't solved this, is this postmenopausal osteoporosis, and is the decline in her bone density and her trabecular bone score purely because of menopause? And you can see menopause has in fact been confirmed. Or is this in fact normocalcemic primary hyperparathyroidism based on a combination of a profound bone loss, a very low trabecular bone score, and a huge decline? She had multiple constitutional symptoms which are in keeping with primary hyperparathyroidism. Against that is that the BMD at the 1/3 radius was normal. And then in favor, we did a neck ultrasound and a sestamibi scan, both of which confirmed a left inferior parathyroid adenoma. Unfortunately, further management has been delayed because of COVID. They closed all the non-acute surgery. So we're waiting for her to be seen by the endocrinological surgeon. The next patient is a 71-year-old male. His clinical risks for fracture include a maternal hip fracture, and he's had bilateral proximal humeral fractures. He's been on treatment with Fosavance for the last 3 years, together with 500 milligrams of calcium and 1,000 units of vitamin D3 a day. These are his bone density readings. You can see his T-score at lumbar spines minus 2.3 standard deviations. And you can see the significant increase in bone density while on the oral bisphosphonate. Similarly, at his left femur, we always use the left femur total for follow-up measurements. And their bone density went up initially, slightly down initially. Neither of these changes is outside of the precision error of the machine, and hence neither is significant. And this is his other hip. Once again, you see on this occasion a slight increase followed by a slight decrease. Once again, not outside of the precision error of the machine. So we're seeing a significant increase in lumbar spine, and generally that's the most accurate site for follow-up. And no significant change at the hip. Just for completeness, you can see, although we didn't need to do this because his T-score was minus 2.5, but you can see based on his low bone density, even at the hip where the T-score was minus 1.8, you can see his 10-year probability of hip fracture is 7.6% based on his clinical profile and his DEXA. His trabecular bone score is slightly low at 1.233, certainly confirming the osteoporosis. And you can see here the effect of treatment on TBS. You can see the TBS increasing year by year. So a total increase of 5.6% over the 2 years. There's the year-by-year increase. Next patient is a 65-year-old female, menopause at age 50, and she's been on menopausal hormone therapy ever since. And then at the age of 60, about 10 years later, she develops a fractured left humerus and moderate to severe fractures at the 11th dorsal and 2nd lumbar vertebra. Based on these new fractures, I then initiated treatment with anabolic therapy. And I followed that with a cluster infusion, that's intravenous bisphosphonate zoledronic acid, in 2019 and 2020. This is a vertebral fracture assessment, and you can clearly see the two fractures. There's the one, and there's the other, and you can see kyphoseplasty cement in this one. This is the lateral view, and that's the AP view. Obviously, her bone density readings at lumbar spine are completely inaccurate because of the fracture and because of secondary osteoarthritis there. You can, however, see the significant increase in bone density by 8.2% subsequent to the teriparatide anabolic therapy and then the anti-resorptive agent zoledronic acid. Similarly, you can see a decline in bone density prior to treatment and then an increase in bone density. So that's while on menopausal hormone therapy after the teriparatide, and then the increase in bone density after initiating a cluster, zoledronic acid. And similarly, at the right femur, a slight decline in bone density prior to initiation of the zoledronic acid, which then stabilized bone density. And you can perhaps see these changes more marked. This is just a picture of the femurs. We can check a bit of cortical thickness there. And then you can see the changes on her trabecular bone score. You can see her trabecular bone score is reasonably good. And you can see the decline in trabecular bone score by 3.9% prior to initiating the zoledronic acid, which then resulted in a 9.7% increase in trabecular bone score. The next patient is a 66-year-old female. In 2017, she had a borderline bone density and trabecular bone score. In 2018, so we treated her conservatively at that time. 2018, she has an 8% decrease in bone density at lumbar spine, and she's now certainly osteoporotic. Similarly, a decrease at the proximal femur sites, where bone density decreased by 8%. Her trabecular bone score decreased by 11.6% and is now very low. And she had a Colles fracture in April 2018. Based on all of that, she more than satisfied criteria for treatment, and she had zoledronic acid infused in 2018 and 2019. The bone density remains stable, but this is her trabecular bone score. So there you can see the decline in bone density prior to treatment, as I told you, by 11.6%, and then a subsequent increase in bone density by about 6% subsequent to initiating zoledronic acid. So you can clearly see the trabecular bone score here offers additional information on decline in bone density prior to treatment and an increase in bone density subsequent to treatment. This patient is a 69-year-old patient who has a medical history as shown, no risk factors for osteoporosis. This is her vertebral fracture assessment, which shows no fractures, a little bit of osteoarthritic change at the spine, which would spuriously elevate bone density there. Her spine DEXA was in fact completely inaccurate. This is her bone density at the left femur, femur neck minus 2.3, femur total minus 1.7 standard deviations. On her FRAX score, we're using a T-score of minus 2.3 standard deviations. You can see her 10-year probability of a major osteoporosis fracture is 12% and a hip fracture 2.9%. So she doesn't quite, based on the FRAX model and recommendations of treatment, she doesn't quite reach the 3% or 20% risk profile for treatment initiation. The trabecular bone score is slightly low at 1.235. And once again, there's a slight decline in trabecular bone score. So you're a little bit concerned that her trabecular microarchitecture as measured by TBS is decreasing. Okay. If you then add trabecular bone score, you can see her 10-year probability of fractures now increased from 2.9 to 3.2%. And based on your fracture risk algorithm assessment, she now falls into the pattern of high fracture risk and therefore qualifies for treatment. Next patient, a 76-year-old, we're nearly done. Maternal hip fracture, previous treatment with Fossavance, which she stopped in 2016 because she assured me it's very bad for the jaw. Despite my protestations and further information, she steadfastly refused to take treatment. This is her bone density. You can see the progressive and significant decline in bone density by almost 11% over the 4-year treatment while she remained off treatment. This is the bone density at her right hip. You can see there's some arthritic change at the right hip, so it's not completely accurate. And because of that arthritis, the changes in bone density are not strictly accurate. The trabecular bone score might add some assistance, so you can see her trabecular bone score is modestly low. And if you follow her trabecular bone score, you can see the significant decline in trabecular bone score, in particular in the last 12 months. So based on that information, I was able to show her the decline in bone density based on DEXA and the decline in bone density based on TBS, and fortunately managed to persuade her based on those two factors to reinitiate treatment. This patient's an 84-year-old patient, first seen in August 2018. This is a very interesting case. The trabecular bone score was low at 1.166. She had fractures at T11 and L2. She's a different patient from the one seen before. And her T-score at 1/3 radius was very low at -4.9 standard deviation. The T-score at L3 and L4, which were the only two accurate sites, were -4.2 standard deviations. And she had osteoarthritis of both hips. She was diagnosed with primary hyperparathyroidism with raised PTH, a raised calcium, and a positive sestim-EB scan, and she had a parathyroidectomy in January 2019. And when seen a year later by me, she had an cluster infusion of zoledronic acid. There are the two fractures. There's a mild fracture there, that's at L4, and a moderate fracture there. This is her T-score at 1/3 radius. Now it's -4 points. So this is after the parathyroidectomy done in 2018 and the subsequent infusion of zoledronic acid in 2019. You can see a significant improvement. Generally, you don't get an improvement in bone density at 1/3 radius with bisphosphonates, but you can see she's got a highly significant increase in bone density. Her bone density is obviously still very low. You can see the arthritis here at the left hip, but we can get a decent reading at left femur total. And you can see again a highly significant increase in bone density subsequent to parathyroidectomy and bisphosphonate infusion. This is her trabecular bone score, which was in fact reasonably good initially. But you can see the massive improvement in trabecular bone score after successful parathyroidectomy and initiation of bisphosphonate treatment. I think this is the second to last case. This patient was diagnosed in 2010. Bone density was low. She was treated with Protos and calcium and vitamin D. She was then stopped treatment. She stopped treatment in 2017. Her trabecular bone score was still reasonable, and she was treated conservatively with calcium and vitamin D. She was seen a year later. She was generally well, but she was complaining of night sweats, and her bone density had dropped by 5.7%. I investigated her further and picked up a M protein IgM kappa band at 15 grams per liter. And following further investigation, she was diagnosed with a Waldenstrom's macroglobulinemia, which was treated by the oncologist, and I added zoledronic acid. The bone density readings are interesting. You can see the highly significant decline in bone density while off treatment and prior to the diagnosis of her Waldenstrom's. And then subsequent to the treatment of the Waldenstrom's and initiation of the bisphosphonate, there's a 5% increase in bone density. And you can see similar readings at the other hip, significant decline in bone density, and then following appropriate management and increase in bone density, and the same at the other hip as well. You see the decline in bone density prior to treatment, increase in bone density subsequent to treatment. And you can see the same thing on her trabecular bone score, a decline in bone density prior to treatment, and then an increase subsequent to initiating treatment. So those are the cases I have. Hopefully I've given you some information on where TBS can assist you in patient management and how you can use it, both in terms of improving your diagnosis and improving your follow-up to treatment. So thanks very much. I'll stop screen sharing. And Toby and I are available for questions.
Well, thank you very much, both of you, for this excellent presentation and this very rich sharing of your experience. Dr. Lipschitz, it was very, very clear. We have some questions. I would like to, because it's an often question that I actually see often as well, is in terms of reference curves. Both of you can answer these questions. In terms of reference curves and for TBS, may you share your experience and with the different ethnicities that you see?
You know, we don't have data in South Africa, certainly, so we're just using a standard. I don't know, Toby, do you know anything about different ethnicity curves? As far as I'm concerned, there isn't any.
There are no ethnicity curves for South Africans for TBS, but the ethnicity curves for DEXA being used for the FRAX model will be different between whites, coloreds, Indians, and blacks. And that's the data that has been published now by Professor Kassim and a team from KZN. So I do not have any particular reason to believe that it will not be the same for TBS as the two correlates. And there will be, if you use, when available, the new South African FRAX model, and you adjust for TBS using the right ethnicity group, I think it will automatically correlate for that, but that will be based on the DEXA values.
Okay, thank you very much. We have a question regarding biopsy. So the gold standard is obviously bone marrow biopsy. And what is the correlation between TBS and bone biopsy?
Antoine, I think that you can probably answer that more specifically than either me or Stan, because I haven't got the literature right here. But it's just a normal bone biopsy. It's actually bone marrow biopsy, just a bone trabecular bone biopsy, and have seen the correlations, and that was fairly good. But maybe you can be more specific on quoting which paper I've read.
Yes, on the technical aspect, and thanks based on the very good presentation of one of the slides, which were comparing with the trees and the analysis that we done. In fact, the TBS has shown good, excellent correlation between the high resolution of an image through biopsy and the DEXA. How by applying be able to apply TBS on even ex vivo vertebra and be able to, by degrading the size of the quality of the image, applying TBS on both images, one high resolution and one degraded, but same vertebra, would show high correlation between these two. So in fact, biopsy, where we see the trabecular and the DEXA from a pixelized image, were showing great correlation from this extent. So from the technical point of view, also the physical aspect, that's how TBS is correlated to this.
I could just maybe add that the transiliac bone biopsies are basically only used in the research context. And I did quite a few of them in my life, but all in the research context, has not got any role to play in the clinical context.
Mm-hmm. Excellent. Thank you. I have another question. Being a prolonged use of a biphosphonate is said to cause atypical femoral fracture. Can TBS assist to predict these?
But I can answer that. The answer is no, because to assess that, I'd like to comment a little bit on that supposition, but TBS doesn't assess cortical bone as well, and atypical femur fractures presumably occur because of thickening of cortical bone and because of stress fractures occurring. There's been a lot of data published recently on supposed atypical femur fractures. And any of you who tuned into the World Congress of Osteoporosis would have seen some really good talks evaluating the relative risk of an osteoporosis fracture, typical osteoporosis fracture, versus the relative risk of an atypical femur fracture. And really the advantage of even prolonged bisphosphonate or denosumab treatment in terms of fracture risk is about 300 times greater than the very, very low risk of an atypical femur fracture. So in fact, the latest thinking is for patients in the very high risk category of fracture, as I showed you in my slides, you should in fact continue prolonged treatment because the benefit's going to be far greater than risk.
Stan, can I just add to that? There's been a very recent interesting article on the use of oral bisphosphonates with a 30% reduction in the risk of coronary arterial or basically any cardiac risk. So that's fairly high, and it was a fairly robust study that was being done. So normally when people look at the risk to benefit ratio of bisphosphonates, that's never been added to the benefits. And another benefit of osteoporosis therapy is that it's got direct and indirect anti-oncogenic properties as well. So I think we're starting to realize that what started off as an industrial medication or industrial stuff to work on decalcifying pipes actually has far more properties than we ever realized. That's just a side comment on the bisphosphonates.
Excellent. Thank you for these answers. I would like to ask another question. Is related to the new, something that recently came up, the BMD T-score adjustment. It's been recently released, so I know there's no much experience yet, maybe in South Africa, but how, in your extent, how this new BMD T-score adjusted with TBS can help in the daily practice, and maybe also help you taking your decisions based on that, and maybe also FRAX adjusted.
Yeah, perhaps I'll comment first and then you can comment further, Toby. I think it's most useful in the borderline patients. So the one case I showed you where the FRAX probability wasn't quite 3%, if you add TBS to that, you can in fact push a patient into fracture risk threshold or indeed out of it. It's also very useful in situations where it's difficult to measure DEXA, like obese patients, patients with diabetes, sometimes primary hyperparathyroidism. So it's, in that situation, it will help you to further define your risk of fracture, remembering that your prime aim of osteoporosis assessment is to determine fracture risk in order to guide you on how to manage patients, whether to treat them with anabolic therapy if their risk is very high, or whether to treat them with bisphosphonate therapy or denosumab if the risk is moderately high, or whether to go conservative treatment if the risk is relatively low.
Okay.
Yeah, I'll just add to that you use absolutely everything that you can get to make a clinical decision of, and TBS is becoming an essential part of that. But having said all of that, our big problem is still the exact values of fracture risk reduction where you start therapy. Stan has alluded quite directly to the values of 20% for for a major osteoporotic fracture, or 3% for the hip. And that's the American figures. But whether that actually is true for South Africa, we don't know. So we're halfway there by having now developed our own FRAX score prediction. But the next step that NOF will have to address, and Bilkish has already made the correct noises that she'll do that, is now to exactly work out in South Africa what our intervention thresholds should be. But in the meantime, both me and Stan are using the American guidelines, which is easy to remember, 20% and 3%.
Excellent. Okay. Good. Maybe may I ask you a last question in regarding to the practice that you had, and a typical, you have shown already a lot of examples, but the typical group that you have experienced to be really where TBS brings a help for you, a typical pathology could be, and for which TBS helps you to guide you either on treatment monitoring or even fracture risk assessment.
I would say unequivocally that it's for the patient that's in the osteopenic range, just on normal DEXA, and especially where it goes near the value of minus 2.5, say minus 2.3. That's always a difficult one, because although the minus 2.5 is mathematically derived from the, and it is a valid, it was never meant as an intervention threshold. It was meant as an epidemiological cutoff to compare the rates of incidence, for instance, between different nations. So the patient who approaches minus 2 point, anywhere between minus 2 and minus 2.5, I think is the patient that most benefits from it. But as we said, it's also for patients with secondary osteoporosis and for the monitoring of therapy.
Yeah, I would agree with that. That's its major use. I occasionally find it useful in practice. I've mentioned the primary hyperparas, but certainly patients with type 2 diabetes, and in particular the obese ones, where fractures are not sort of typical osteoporosis fractures. You very often get distal lower limb fractures. And the bone density is very, very difficult to measure. So as Toby said earlier, you use everything in your arsenal to try and define fracture risk. And TBS helps sometimes. Very often there you'll have a relatively normal bone density, but a very low TBS.
Okay. Excellent. Thank you so much. We don't have further questions. I want really to thank you for your time, your participation tonight. It was really a pleasure and honor for me to have you with us, and for these presentations. We will keep these sessions open for questions, and if people contact us We will definitely be able to help and guide maybe some questions to you. But thank you for sharing the overall experience with TBS. This session will be recorded and available for later review. If we're all good for tonight, and if there are no further questions or comments from you, doctors, please, we can put it an end. It's been already an hour. Time went very fast. So thank you a lot again, and wish you a good rest of the day.
Good evening, and thanks very much to the audience for listening and for you hosting it.
Thank you.
Thank you very much. May
Well,
everybody warm up tonight.
Hopefully it did. Apparently it's very cold.
Good night.
All right. Good night.
Thank you.